Hello, talking of facial neuralgias. You know that facial neuralgia is as a result of neurogenic pain, which can be of bright, stimulating quality. Sight is accurately localized in this type of pain and it bears anatomical relationship to the site of origin. So an analgesic block is useful diagnostically. The pain is extremely intense as compared to the stimulation, so no central excitatory effect like a referred pain is seen in this type of pain, and presence of trigeminal is characteristic feature of this pain. There is paroxysmal nature, that is, there are sudden bursts of intense stabbing pain along the course of the nerve. These can be categorized or seen in trigeminal neuralgia, glossopharyngeal neuralgia, geniculate neuralgia. Now coming to trigeminal neuralgia, which is one of the most commonly found neuralgia amongst the facial regions. It may be primary, which is idiopathic, or secondary, which may result from trauma or any central nervous system lesion. It is characterized by sudden violent attacks, which are called as paroxysms of fleeting type of pain, often like electric shock. The pathophysiology of trigeminal neuralgia includes the compression of trigeminal root or a large myelinated fiber. There is demyelination, which occurs as a result of compression, and the hyperexcitability of the fibers is there, which results in excessive pain. The clinical features of this type of neuralgia they include: this is commonly seen in 5th to 7th decade of life, and there is female predominance of this type of neuralgia. The pain is sudden, unilateral, intermittent, paroxysmal, sharp, shooting, lancinating type, which radiates from a point across the distribution of one or more branches of the trigeminal nerve. As we all know, there are three branches of trigeminal nerve: the thalamic, maxillary, and the mandibular. Pain is of short duration and it lasts for a few seconds to a minute only. The patient may wince on account of intense pain. Wincing is one of the expressions, and hence the term tic is used for the description. Pain may occur during day or night spontaneously by the movements of the facial muscles. Trigger zones are present on the face, lips, or tongue, and each episode persists for weeks or months, followed by a refractive period which lasts longer than a few months. The right side is most often involved than the left side, and involvement of the ophthalmic division is very, very rare. The other two branches, maxillary and the mandibular, may be involved simultaneously in some of the patients. The treatment of trigeminal neuralgia consists of medicinal treatment or drug therapy and the surgical treatment. The commonly used drugs which are of help in trigeminal neuralgia are carbamazepine, which is initiated with 100 mg per day along with food, and the dose can be increased gradually by 100 mg once in 2 to 3 days till about 50% of the relief is achieved. So the maximum dose which can be given in such patients is about 1200 mg per day, above which there is very little benefit of this drug. Then after attaining the relief, which is about 100% relief, the maintenance dose of 200 mg QID is given, usually for a long period of time. Excuse me. There is dizziness, sedation, imbalance, and agranulocytosis as side effects of this drug. So in patients where carbamazepine is not giving much relief, we use phenytoin, which is given in doses of 300 to 400 mg per day, and the side effects which are seen with phenytoin are gingival apoplasia, folate deficiency, slurred speech, and hirsutism. Then baclofen 5 to 10 mg TID is also given, which is gradually increased to 20 mg QID, and the side effects which are seen with baclofen are drowsiness, nausea, vomiting, fatigue, and unsteadiness. The surgical treatment of trigeminal neuralgia, it includes injection therapy, which includes injection of long-acting anesthetic agents like bupivacaine, alcohol blocks, which are given around the nerve trunk itself. Then there are peripheral neurectomies, which can be done. Then glycerol rhizotomy, which is done near the Gazerian ganglion. and radiofrequency thermal rhizotomy also done at the ganglion, microvascular decompression to relieve the pain, relieve the compression by the vascular component onto the nerves. In cryotherapy, nerve is frozen by direct appreciation of cryotherapy probe at temperatures colder than -60 degrees centigrade. These have been utilized for giving relief to patients of trigeminal neuralgia. And there is a video which is showing a patient of trigeminal neuralgia. It was taken in yesteryears when I was doing my post-graduation, and it will clearly show the amount of intensity of pain which the patient is suffering in his facial expressions, in the eyes and on the facial muscles, which I have seen as the patient is constantly biting upon his lips and the cheek to get relief from the pain, which is sporadic, which is of a few seconds momentarily, which is just like electrifying pain, which occurs every now and then. And this episode is persisting for about a minute or so, and after that the patient will be relieved. So we can see this patient going through this trauma continuously for a minute or so, in which the patient is having excruciating type of lancinating, stabbing or electrifying pain. Now this type of pain, when it is relieved by the medications, the patient is able to move on to the routine life for a few days or so. So as you see in the video, in this trigeminal neuralgia, he was managed by medicines only. And for medicines also do help for a long time, till the time the side effects become more intense than the benefits. So we switch on to surgical treatments. Then we come on to glossopharyngeal neuralgia, where paroxysmal pain is there, no doubt in this also, and less intense pain is there along the distribution of the glossopharyngeal nerve, which will show it or manifest itself in the pharynx, posterior tongue, ear, infra-auricular and the retromandibular region. The pain is triggered by chewing, talking and swallowing, all which stimulate the pharyngeal mucosa. In the trigeminal neuralgia, it was the stimulation of the facial muscles, facial skin also. There were trigger zones which were present on the face, lips, tongue, which will stimulate the pain. Then the diagnosis of this type of neuralgia is application of topical anesthetic to the pharyngeal mucosa, which eliminates the glossopharyngeal neuralgia. Then it can be diagnosed as such. The treatment involves the utilization of carbamazepine and baclofen as drug therapy, as it was given in trigeminal neuralgia, and for surgical therapy, intra or extracranial neurectomy, microvascular decompression, thermocoagulation can be utilized. Then geniculate neuralgia. It is for the geniculate ganglion, where it involves the pain in the ear, anterior tongue and the soft palate. The pain is less sharp and intense as compared to trigeminal neuralgia, and it is secondary to herpetic zoster inflammation of the geniculate ganglia. Say Ramsay-Hunt syndrome, the Bell's palsy, unilateral ear vesicle and ulcers of oral mucosa which occur in this syndrome. It can also be seen in this syndrome. The treatment involves the utilization of carbamazepine and the antidepressants, and antiviral therapy is given if it is secondary to herpes zoster. Then post-herpetic neuralgia, episodes of severe lancinating or burning pain occur at the site of former eruptions and are more common in older persons in the 5th to 6th decade of life, and there are no trigger zones. The treatment of post-herpetic neuralgia is the short-term high-dose systemic corticosteroids is given along with tricyclic antidepressants like amitriptyline. Topical capsaicin therapy is given, which is effective on selective C fiber neurotoxin. It depletes the substance P, a neuropeptide which causes the burning sensation. Therefore, the response is characteristic of second-order neurons in this case. And blocking of the sympathetic ganglion, where mixture of local anesthetic and steroids is utilized. Thank you so much.